So I'm going to lay the foundation for the, provide an overview of what the challenge is all about. Isabella is going to talk about Navicent Health. She's the Director of Innovation for Navicent Healthcare. And a lot of us in North Georgia may have heard about Navicent, but we really don't know that much about them. But they are, the largest healthcare system in Middle and South Georgia. And so we wanted to lay the foundation so everybody knows who we're listening to there. Then we're going to have two CEOs talk about two respective challenges, one about rising risk beneficiaries, and then one about pediatric asthma. And that'll be the core part of the program tonight. And then we'll cover the next steps for the phase 1, the next 5 weeks, and subsequent phase 2 over the next 8 weeks after that. Okay. I want to make sure I'm stopping this, so give me a little learning opportunity here. So there's a lot of ways to collaborate. There we go. And okay, Chris is going to learn this sooner or later. Make sure it stops here. Okay, so obviously our 4 organizations are collaborating tonight for this event. This is a bit of a unique program, if you will. But for example, Georgia HIMSS and TAG Digital Health, we collaborate on 1 or 2 projects every year. We'll also collaborate with ATV or ATDC. All those organizations collaborate with each other. We'll also collaborate with Georgia Bio or Healthcare Connect South or some of the other incubators around town like GCMI. We also partner with the Bioscience Council for the Atlanta Chamber, and also some of the other societies and organizations, as well as the CDC and all the universities that we have around the state, particularly Georgia Tech and KSU and Georgia State. So there is a lot of collaboration going on, but there is not a lot of collaboration going on between medical providers and technology providers. And Christopher Cunny and I were talking in March of last year about how our 2 organizations, so he's on the board of Georgia HIMSS and the past president, and I'm the chair of TAG Digital Health. And we're trying to come up with some way where we could help foster collaboration between those 2 parts of the ecosystem, medical providers and technology providers. And we came up with this idea of a reverse pitch. And the idea is a forward pitch. A regular pitch is we have maybe an entrepreneur. He's pitching in front of hundreds of investors. Think about Venture Atlanta, the major investor conference in October in Atlanta every year, where an entrepreneur gets up, gives a 5-minute pitch with the idea of identifying some investors who are interested in investing in him, perhaps, or her, and then they establish a relationship and it results in an investment. It's more of a one-time effort, even though there's preparation before that. The idea of a reverse pitch is where you have the person who wants to buy the product, in this case, Navicent Health. They want to get on stage and share some problems or a problem that they can't solve on their own. They know they would like help. They've been looking in the marketplace and they can't find anybody who has that solution. So they're willing to open the kimono up and share it with the technology community. And tonight they're inviting you, all of us, to actually propose our ideas to help them solve some pain points, some problems that they have. So, but it's not just a one-night event tonight. In 90 days, on October 29th, we're going to have the forward pitch. So tonight's the reverse pitch. And then we're going to put the finalists on stage to present at another event. There's going to be 3 to 5 finalists for each of the 2 challenges that we have. And we'll walk you through how we get there. But there's an opportunity there. And then that night or the next day, Laura and Dale are both going to choose a winner in each of the respective challenges, and then go into beta tests sometime by January. So just want to let you know how we have framed out this this challenge here. So that's what we're thinking about here. Okay. I mentioned that Christopher and I started thinking about this March of last year. And as we started, we were looking for a healthcare system to partner with. So we talked to a few around the state. As we were doing this, we started talking with other people, and we ran into A.T. Gimbel at Atlanta Tech Village. And A.T.'s on the program tonight with us. And he was looking at doing the same thing. In fact, he'd already had some preliminary conversations. So we decided to partner up. So all three of our organizations here, we are partnering with this. And we started looking, we talked to a number of institutions around systems around the state. We met Isabel in November at the Tag Health Summit that we had at that time. And she knew all of us anyway. And so once we started talking about it, she showed a lot of interest. Fast forward 3 months, end of February, we reached an agreement where they would be our provider. And so we've been working since then to identify particular challenges to put before you guys tonight. Okay. So specifically about this challenge, it's 13 weeks. It has 2 phases. Phase 1 is 5 weeks. It starts tonight, if you will. Next Tuesday, each of the 2 champions, the 2 CEOs, they're going to have their own independent sessions. So if you're interested in either of those challenges, you can go ask Dale or Laura. You can go sit in on those sessions and ask them questions. They're going to be live with questions. So we'll be there to help moderate, but you'll have definitely some exposure and opportunity to connect with them. You'll have a month going through August 28th to actually propose. That's the deadline to propose, and we have a format. It doesn't need to be super complicated or anything, but we're going to collect some basic information, and we invite everybody to propose. We'll have some coaching sessions through some subject matter experts in between those 2 dates to help you guys form up your proposal, to give you some guidance on that. And within a week of that date, Dale and Laura will pick finalists, the 3 to 5 finalists for their respective challenges. And then the next 8 weeks are to help those finalists go through their work to help refine their pitches that they will give on October 29th. And so there will be some sessions with the CEOs and also sessions with that are available with the coaches as well. Okay. So the idea is to pick 2 winning companies to go into tests soon thereafter. Okay. So just high level, who's involved? The healthcare provider, we've got one, Navicent Health. They want to do this because they got some problems they need help solving. And so they're really crowdsourcing, if you will, in a way, their problems, their opportunities, if you will. The healthcare technology providers, a lot of you guys in the room tonight, you're looking for a way to access a major healthcare system and maybe to pilot your service. And it doesn't have to be a new service, even though it can be. It may be an existing service or product or solution. And if you just customize a little bit, it'll meet their needs. So that's awesome too. And then of course, the reason that ATV and Georgia HIMSS and Tag Digital Health are in this is, one, it's some nice programming, but more importantly, it's a way to for us to help foster collaboration between those 2 communities. And it really begins to provide value add to the healthcare community around the state of Georgia. Here is the leadership team for the Innovation Challenge team. You see myself here. You will meet Isabel next, and then A-Team Christopher here soon. Okay. We also have a larger steering committee that includes additional people like JC Lucas, who you heard while we were warming up here, and also Cindy and Megan, as well as the 2 CTOs from Navicent Health, and Sept Browning, the president of Georgia HIMSS, and Kristen O'Neill with 2 Locks 9, who's working closely with digital health as well. So I would like to ask AT Gimbel to give you a little bit more background on ATV and also Atlanta Ventures, so that you understand why each of these 3 organizations, why we have the background and the cloud to be able to actually put on a program like this. AT?
Thanks, Chris, and thanks everyone for joining. We were excited to be partnered as part of this great event. And just to start, a little more background on Atlanta Tech Village and Atlanta Ventures. So Atlanta Tech Village was founded by a serial entrepreneur here in Atlanta named David Cummings, who's launched multiple successful businesses, and at the time really understood the power of community to build things. And so founded the Tech Village with the idea of building that community where you could go build a tech business together with others and working collaboratively on the idea itself, on the talent and the people you're hiring and learning from, as well as finding access to capital to build and grow your business. And so Tech Village is now the 4th largest tech hub in the United States. It's got 100,000 square feet, 5 stories. You've got over 1,000 members, 300 companies in there. And it's just a great place to come and work together and build businesses. So if you're an entrepreneur, it's oftentimes a lonely journey being in your basement, thinking and going through all the ups and downs, but here you've got a community to help support you. Many of the Atlanta Tech Village companies have gone on to a lot of great success, raised a lot of money, had some strong exits, and more importantly, created a lot of jobs here in Atlanta. So you've had companies like SalesLoft or Calendly or Terminus that are fast-growing companies here in Atlanta. You've had companies that have exited like IO Education or Clockwise MD, Mike Burke's company here that started in the healthcare space. And then lastly, back to that community, one of the things we started about 2 years ago, specifically for healthcare, was the Atlanta Healthcare Entrepreneur Meetups. And it was the idea of connecting entrepreneurs, folks in the ecosystem, and people who have healthcare problems to better understand and talk with each other and connect together. And so we've started that over 2 years ago. We've got over 1,000 members in the group. We hold regular meetups every 6 to 8 weeks. Obviously with COVID, we've gone virtual, but they're typically at the Tech Village in person. And we've had speakers ranging from successful CEOs of healthcare companies to folks just getting started, investors, folks in the hospital systems across the board. So it's a great way to connect with folks in the healthcare system here.
Excellent. Thank you, AT. Now, how many companies do you have in the village between healthcare and healthcare technology?
I'd say probably about 10% of the companies, Chris. So you probably have 30, 40 companies that are healthcare related. And obviously that continues to grow as you have a fintech company, but that's working in healthcare. So you can define those, and that probably expands it further.
Excellent. All right. Well, thank you very much for that. And let me go to, make sure the page stops. Christopher Cunney with Georgia HIMSS.
Good afternoon, everyone. First of all, I want to just say how excited I am to be here this evening and to see, this concept that Chris and I had, a little over a year or so ago, become a reality. I know both of us are strong proponents of healthcare technology in our region, and we've been supporting that for a number of years. And we felt like, there was a missing link between the provider community and the tech community. And it's so nice to now be able to birth something like this. And we hope this won't be the first time we do this, that this becomes an annual event. I'm here representing Georgia HIMSS and the HIMSS organization as a whole. And for those of you who may not know who HIMSS is as an organization, HIMSS stands for Healthcare Information Management and Systems Society. It's arguably the largest healthcare technology association in the world. We have chapters in every state and in Europe, South America, Canada, Asia Pacific, literally across the world. And in fact, the Chief Administrative Officer for HIMSS is actually based here in Atlanta, Dr. Denise Hines, who is actually former president of our local chapter as well too. And for those of you who also may not know, that HIMSS as a national organization actually started here in Atlanta, Georgia, actually started at Georgia Tech. And has grown to be this national organization that supports well over 60,000 plus 100,000 plus members in certifications, education, thought leadership, and healthcare systems in adopting and leveraging and maximizing technology. Georgia HIMSS as a chapter has been one of the premier chapters within HIMSS as an organization. We've won Chapter of the Year in the past. We plan to win it again. We've actually had a Chapter Leader of the Year as well too, who ultimately became now leader of the entire HIMSS organization. We are very proud to say that we award on an annual basis scholarships to individuals who are interested in pursuing careers in healthcare IT. And in fact, this year we awarded over $40,000 in scholarships to well-deserved individuals. Our organization, like many organizations, have had to go virtual as well. And so we do have a wide variety of events we still do on almost a monthly basis. We have something going on. In fact, this past evening, we had a network reception and wine tasting that was a lot of fun. So we're adapting to the new norm. For those of you who are interested in pursuing careers in healthcare IT, collaborating with healthcare organizations about their technology challenges, getting certifications or education in healthcare IT, I highly recommend you consider joining HIMSS, Georgia HIMSS in particular, and becoming an active member of the chapter. I'm also excited to partner with the folks on the call today to bring this event forward. It's been a pleasure to work with each and every one of them, and I look forward to a successful event going forward. Thank you. I'll turn it back over to you, Chris.
Thank you. I was sitting there talking away and not paying attention to that. Thank you. I'd like to take a minute here to tell you a little bit more about the Digital Health Society of TAG, because if you're coming from Navicent or Georgia HIMSS or ATV, you may not be as familiar with us. The Technology Association of Georgia is the largest statewide technology association in the country, has about 30,000 members, organized in about 26 different societies. The Digital Health Society is one of the largest and certainly one of the most active of those societies. And we want to be a catalyst for helping further Georgia as a leader in healthcare technology. It's been a leader in healthcare technology since the 50s, and with him starting and founding in 1960 on Tech's campus, and all the stuff that McKesson's done and all the other companies. We've got over 200 digital health /health IT companies officed in Georgia somewhere, with over half of them with headquarters here. So we have a very large ecosystem, and it's in one of the major clusters around the country. We host typically 7 to 10 meetings annually. This year it will be 10, including our annual summit on November 12th. That will be a virtual summit, but it will be a large one, and we are already well into the planning stages for that. We also have an event next week on August 5th. We're partnering with the Corporate Development Society of TAG. That's the M&A investor society, if you will. And so the topic is going to be digital health investing in a COVID environment. So it's going to be a great panel, and we've got some investors and some entrepreneurs involved in that one. So if you're looking for a lunch date next Tuesday, come join us. So we'd love to see you there. But we do love to partner with other healthcare technology, and other TAG societies. So if you're interested, you represent somebody within that sphere, please reach out and give us a call. We'd love to talk with you. Okay, so let me go ahead and move forward. And I'm going to introduce Isabel Magnan. She is the Director of Innovation for Navicent Health. And Isabel is also the committee chair of the selection committee. So of all the people that propose, all the companies that propose on a given challenge, she'll manage the process. She'll be the primary person that you all communicate with as we go through the next 13 weeks, if you will. So you'll want to get to know her, and she's a delight to work with. So Isabel.
Thank you, Chris. It's an absolute pleasure to be before all of you today. Thank you very much for joining. Thank you for your curiosity. I know this is not your typical event. And also, thank you very much to all our partners, TAG, ATV, Georgia HIMSS. This is the power of partnership today that we are kicking off with this 13-week program. All right, next, Chris. Thank you. So I want to tell you a little bit about Navicent today. Navicent Health is headquartered in Macon, Georgia, and it serves diverse populations in Middle and South Georgia. Around urban, we have urban populations, rural, agricultural. Our communities are very varied. There's about 30 counties included in our service area, and 750,000 persons roughly. It is the primary academic hospital for Mercer University School of Medicine, and we provide residency and fellowship programs for over 100 residents. So the map that you're looking at right now, that has the little red icon, shows you where we have facilities. But of course, our service area is much broader than that, since I mentioned those 30 counties in Middle and South Georgia. Next one, please. Thank you. So here you see the continuum of care, and I'm going to start with the flagship hospital. So if you look at the top of the curve, you see acute care. So that's where I am right now. Navicent Health Flagship Hospital is a 637-bed hospital located in Macon, Georgia. It is the second largest hospital in the state. I bet a lot of you didn't know that, but now you do. And the first one in the Southeast, so for the whole Southeast region, the first one to achieve verification as an American College of Surgeons verified level 1 trauma center. So we have all that in Macon. And then if you look at this slide as well, under acute care, we are joined by 5 other hospitals, including a brand new children's hospital. And today you will hear the pitch of the CEO, Laura Gentry, and she's the CEO of the Medical Center of Peach County. So more to come today. Now, if you go back to the beginning, let's go to the community-based, the left part of your screen. So here you see we have Carlisle Place, which is Central Georgia's only life plan community. You can also see that we offer telehealth services from specialists, a wellness center, physician offices, and here it's important to notice the Family Health Center in Macon with its own family health residency program. We have urgent care centers, and Navicent has its own emergency medical services, including special transportation for preemie infants, since we have quite a few NICU beds in our Macon hospital. Now, if you continue on that continuum, you go to post-acute care now. You can see that we have an inpatient rehab hospital, skilled nursing facilities, and hospice care. And at the bottom, you see this sign across the continuum. At the bottom, you can find towards the middle TC2. You see TC2 there? TC2 is our accountable care organization. And today you will hear the first pitch from Dale Boylston, who's the CEO of TC2. So more to come today as well. Next one, please. Now, I'm happy as well to introduce Atrium Health. In 2018, the strategic combination with Navicent Health and Atrium Health was announced. And by the way, Atrium Health used to be called the Carolinas healthcare system. You probably have heard it under this name, but since it branched out of the Carolinas into Georgia, it changed its name to become Atrium Health. So it rebranded when it announced the combination with Navicent Health. And then early in 2019, Atrium Health announced the combination with Wake Forest Baptist Health with the intention of building a medical school in Charlotte. Charlotte doesn't currently have a medical school, so that's the intention there. More recently, Atrium announced a strategic combination with Floyd Medical Center, a system of healthcare providers servicing Northwest Georgia and Northeast Alabama since 1942. And it's located in Rome, Georgia, and it is Floyd County's largest employer with 2,000 employees. So, you know, overall, Atrium Health is one of the largest health systems in the Southeast with 900 care locations, a revenue of $11 billion, and 70,000 teammates. But, you know, beyond the size and the reach of Atrium Health is the impact that we have every day on the communities that we serve, such as our relentless focus on health equity. It is very important to mention that today, given the challenges that you will hear, that all have a health equity element. Next one, please. Thank you. This is a map of the current facilities of Atrium Health. It is not all encompassing of the strategic combination that are in progress that I mentioned right now, but it gives you an idea of the 3 states that we cover. Next one. I mentioned a bit of the numbers already, and I want to stress that as a nonprofit, one of the ways that we give back to the community every day is through $5.6 million of uncompensated care that we deliver to the community. There's many other ways that we bring back to the community. That's the number, the quantitative one if you want. Next one. And I covered this one already. I told you about the $11 billion organization. You have a little more numbers here for those of us who like numbers. And that's it for Atrium Health. If you stick around during the cocktail after this presentation is over, you'll get to ask some questions about Navicent and Atrium Health if you're interested in knowing more. Okay, now it is my pleasure to introduce Dale Boylston. Dale is the CEO of TC2, and he will pitch the first challenge to you. Dale is a seasoned healthcare executive. He brings a wealth of knowledge in healthcare, including innovative care delivery models. Dale started his career in the Big Four audit consulting world and worked his way up to the rank of partner at Ernst & Young. He then went on to continue his career in healthcare, working in virtual health platforms in their early days. And today, as the CEO of the accountable care organization, TC2, he serves Middle Georgia communities. My experience working with Dale is that he's extremely consumer focused and has a real passion for human-centered healthcare. I have found Dale to be an early adopter who gets excited about new ideas, products, and models that have the potential of improving the health of the communities we serve. So I am very excited to introduce you to Dale, who you have your video on. Perfect. You're good to go. Go ahead.
I do. All right, Isabel. Well, thank you for that wonderful introduction. The term that I most frequently identify with, though, when it comes to the leadership of the organization that I have is, I'm the one throat to choke if things don't go well. In terms of a little bit of background, I'm going to build on some of the information that Isabel had shared with you all in the context of population health. Because TC2 in and of itself is an accountable care organization. And for those of you who aren't familiar with the specifics of what that terminology means, we're an organization that takes responsibility, financial risk, and responsibility for the quality of care and the delivery of that care for set populations. Now, TC2's sole focus is around Medicare. Medicare beneficiaries, particularly we participate in what Medicare refers to as the shared savings program. And in that program, we participate in a two-sided risk model. And specifically what that really means is we have an assigned population that we get at the beginning of the year. I'll go a little bit more into that in a minute. Medicare tells us what they expect the spend to be for that population, given their burden of illness, and that's really, you know, the diagnoses that each of those individuals individually have collectively rolled up, and then tell us if this is the target, if we are able to essentially keep folks healthy, typically out of the hospital, out of the emergency room, costing a little bit less, and there are savings against that target, there's a portion that comes back to us. The corollary to that is, of course, if we don't and the expenses run higher than expected, we actually owe Medicare money. So in this role of really working with patients, we work through physician practices. So our job really is to work with the practices that have these beneficiaries, help them take better care of their patients, put in place the support tools, capabilities, and the like that allow them to keep those patients as healthy as possible. And for that reason, we have a huge need to have some insights and visibility into the overall health status of each and every one of the lives that we're responsible for. Our geography, as really Isabel had indicated, covers a similar geography to that which you saw earlier for Navicent, and you see that highlighted in the chart on the left. And Navicent is one of the founding members of this organization. We are now in our 4th year of operation. Next slide, please. Getting started, I always like to give just a little bit of a statistical overview, then we can really talk more about the stories behind the numbers. We are comprised and supported by 4 different health systems, Navicent being one of them, and essentially 85 physician practices across that geography that you saw aligned earlier. Mostly primary care practices, some specialty practices that happen to take primary responsibility for patients, such as endocrinologists and gerontologists and a few other subspecialty areas. Today, we have a responsibility for a little less than 25,000 lives, a bit over the 24,000 attributed lives you have. And just to put that, the responsibility of those lives into perspective, those 24,000 lives represent about $260 million, more than $250 million of spend for Medicare. That is their estimated annual spend for that population. For those of you who are motivated to do the quick math, what you'll see is that's just a little bit more than $1,000 per patient per month. The challenge we have, and Isabella had outlined a couple of those elements, is this is more of a rural, in some areas socioeconomically depressed area. I'll go into that a bit more in just a minute. So many of the practices do not have the kind of resources they would need to essentially upgrade to the latest and greatest EMR and the like, nor are we in a position to tell them they need to pick a particular EMR in order to participate with us. So we essentially, as an organization, are working with practices that have 15 different EMRs in which that patient information is held, in addition to obviously the information that Medicare provides us. Now, a lot of these statistics don't mean much unless you put it in a bit of context. So I'm going to take a couple of minutes to do that, if it's okay with the group. When we talk about the population that we serve, what I always like to start with is a simple statistic. Our 24,000 lives are 46% sicker than the average Medicare recipient. And that's across the board. And we know that because that is how Medicare determines through an HCC scoring methodology what they consider the burden of illness for those patients. Those folks are sicker for a lot of different reasons. Some of that is low socioeconomic status, poor education, low income, family issues, be they family violence, drug issues, transportation limitations. And what that typically results in is some very, very poor health. A lot of these folks, in fact, the majority of them would probably be considered, overweight, certainly many obese, suffering from hypertension, diabetes, and a host of other chronic conditions that for all intents and purposes, make them pretty sick folks. We have, just to create some extreme examples, we had a patient last year who went to the emergency room 100 times. We have many who are in the emergency room 20 to 40 times a year, more than once a month. Even the averages are relatively high in that. So for us, there's a basic philosophy under which we operate, and that is, and I always apologize to my health system executives when they hear this, but for Medicare patients in particular, nothing good ever happens in the hospital. So how do we keep them out? How do we keep them healthier? How do we identify health issues before they become major problems? To do that, we have really two primary threads of activity. One is we have some basic analytics based on data that we have. And I'll talk a bit more about that in a minute. The other side of that equation is we try to create outreach capabilities that go beyond what the practices, the physician practices can offer. Many of them are busy enough just taking care of the patient when they show up, in their office. We'll tell them, Mrs. Jones, you need to lose weight. You need to make these changes. We need to make sure you're taking your medications. And there's no ability to follow up on that. We essentially run in the regions, and we break our geography into about 5 regions, what we call population health centers, where we actually have the ability to reach out telephonically to patients to make sure they're taking their medications, to make sure they're just doing the basics of what they need to do. We have social workers who actually then can reach out when we have those social determinants of health, some of those that I outlined earlier. And when we really need to, we're even willing to send out a paramedic to the home to really take care of a patient that is a very, very high risk of emergency room visit, where for this population, if you go to the emergency room, there's a very, very high likelihood you're going to end up in the hospital. Next slide, please. So before we get into this in more detail, a couple of quick definitions, and this won't take but a minute. You'll hear me refer to CMS, that essentially, for those who don't know, refers to the Centers for Medicare Services, or Medicare. Medicare doesn't speak in terms of patients. They speak in terms of beneficiaries. And whenever we, start to use patients in the verbiage with them, they're always quick to remind us beneficiaries is the appropriate way to refer. And the challenge that we're going to talk about next is really about what we would call rising risk beneficiaries. Those are those beneficiaries with chronic conditions and some recent clinical activity, maybe an ED visit, maybe a hospitalization, maybe a number of follow-up visits with a practice with a diagnosis of something rather significant. And these are folks that we expect, if we don't intervene using some of the tools and interventions that I talked about earlier, if we don't intervene with them, in all likelihood, they're going to end up in the ER. They're going to end up in the hospital. And that's going to happen more than once over a period of time. Because once they actually have had multiple ED visits, let's say 3 or 4, or they've been in the hospital more than twice within a 6 to 8 month period, they're already high risk. At that point, the horse is out of the barn. What we're really trying to do is essentially manage them, and we will do that. Our biggest weakness, though, is based on the data that we're able to use today and the analytics that we have, is how do we identify those patients who are rising risk, those who, if we don't do something, if we don't intervene in some way, shape, or form sooner rather than later, they are going to be our high-risk patients, and they are going to be expensive. And again, to the theme that nothing good ever happens in the hospital, not only is it not a good experience to be in the hospital for a Medicare recipient in particular, but really for anyone overall, it's also extremely expensive, $10, $50, $20, $50,000 for some of these admissions, depending on intensity and length of stay. We're hoping to avoid that. So next page, please. So let's talk a little bit about what we have to work with today. Because we participate in the MSSP program, Medicare provides us on a monthly basis a comprehensive data file that actually includes what I would call paid claims. In other words, it's claims data for which they've already processed, approved, and are ready to issue payment or already issued payment. So it doesn't take a genius to figure out that that information comes 45 to 75 days after the date of service. So yes, we get comprehensive information on absolutely everything, every diagnosis, every claim, every time they put their Medicare card down for any service whatsoever anywhere in the country. But it has a substantial lag. I also talked to you earlier about the fact that we essentially have to work with practices that essentially have 15 different EHRs. We are able to pull additional clinical data, lab values, other information sooner from the practices directly, but we have to pull that information. And we don't necessarily have the staff to do that for anything but those patients typically that are very high risk. So while we have that lookup, we don't really have the ability, to very quickly pull in that information to enrich the picture. So like every other ACO, we do have what is called a population health management tool. We use one called Health Endeavors. Why do we use it? First off, that decision was made before I joined, but more importantly, it's a relatively inexpensive tool which pulls in the Medicare data and allows us some analytic capabilities. But in and of itself, it has huge weaknesses. We can't do year-over-year trending information. It keeps each calendar year, which is a Medicare performance year, separate. It has huge limitations in terms of our ability to do look-backs on that. Even though Medicare, when we have a new patient come in at the beginning of each year, let's say a new beneficiary, we do get 3 years of history for them. But it's very, very hard to use the tool to actually do those analytics, both looking retrospectively and also getting timely, meaningful information that we can analyze. From our standpoint, we have not been able to identify an effective, cost-effective, off-the-shelf solution that actually could fit into that actually can pull from Medicare, can pull from Health Endeavors, and can pull together some of these disparate data sources that we're able to help us identify these folks more quickly. And, as you've already heard, this is important because these folks, due to low socioeconomic status and the like, are high needs individuals that oftentimes aren't going to reach out to us in advance, aren't always going to be proactive about their health, but definitely have needs. that we want to be able to meet before they become very, very sick and expensive beneficiaries. Next page. Next page, Chris. I'm sorry. There we go. So the key components for us of a potential solution. Okay, I'll start with cost effective. A couple of reasons for that. One, we're a relatively small operation. We essentially support a population that's socioeconomically disadvantaged. And most importantly, Medicare does not pay for what we do, any extra than what they pay the practices and the hospitals for the services provided. So we actually have to rely on the health systems to continue to invest in our developing the population health centers, the analytics, and all the capabilities that are really designed to keep these folks, happier and healthier. The solution we're looking for has got to obviously first be able to pull in what we use today, which is the CMS data that I referred to earlier, and any other clinical information that we're able to pull. Assistance with how we pull that information out of some select EMRs would also be great. The other item that really is going to become increasingly important in the near term, and this is important for any ACO that's wrestling with analytics, is the rapid growth of HIEs, health information exchanges in the state of Georgia, statewide, such as Gracie, and one that's a national, such as Care Quality, are going to give us the ability to centralize and move some of this data around. If a patient that is attributed to us, that I have responsibility for, is seen at a hospital that isn't one of our participating hospitals, let's even say up in Atlanta, through these HIEs, we're able to know very quickly, okay, that they were admitted up there. So that essentially enriches the data set from which we're able to do our predictive modeling. But most importantly, it's able to use these disparate sources of data to help us identify these rising risk patients. We already know the high risk patients, and typically we're putting the resources in to do that. But our problem is that's where the vast majority of TC2's resources go, is towards the high risk because of the cost that they're incurring right now. And if we're not able to more effectively target that rising risk and redeploy some services early, well, all we're doing over time is just adding to our high risk list. In the end, this has got to be easy for our physicians to use. Now, I will say this. Generally speaking, we'd like them to be able to access, but TC2 pretty much does most of the analytics more centrally and pushes out the information they need to the practices because they don't have time to do that. So do consider, as you think about this, the fact that most of this would be centralized to a small team, and TC2 has about 14, 15 folks that essentially work, full time in doing the work that I've been describing so far. Next page. So for us, what are we trying to do? For the folks who are doing that care management, and that's both at the practice level, at the physician practice, coordinated with the resource we have at TC2, is that we can better focus on those rising risk folks before they're high risk. That we can get the physicians to do so as well, because again, we can't do this all on our own, and the physicians really want to be responsible for taking care of those patients, but we have to help them identify that. A primary care physician might know what they're doing for their particular patient, but they don't know what other 3 specialists, that patient might have seen, and what those other specialists are prescribing, and what else they've diagnosed unless the patient tells them. And we've got to find a better way to address that because the patients typically don't share it or don't remember to share it. So those proactive interventions are going to allow us to keep these folks healthier. And in the end, if they're healthier, what we'll see is this: fewer ED visits, fewer admissions, and even more importantly, fewer readmissions, folks coming back within 30 days because their issue either wasn't fully addressed or they weren't able to follow the discharge directions or the prescriptions they were given or what have you, and as a result of not doing their part, end up in the hospital nonetheless. The final point here, impact: we are not the only organization that faces these types of issues, because in many cases, there are some big, massive solutions out there that are incredibly expensive and involved, but there are literally over 600 ACOs across this country. many of whom are, taking care of anywhere between 5,000 and 50,000 members. We're kind of in the middle of that. And there, it's all about cost-effective decision-making, but they're facing the very same sets of issues. And then just to the last slide that I think I've got on my deck here. So what does success look like? Well, obviously, you've heard it enough. We do a better job, of identifying rising risk. Fewer admissions, fewer revisits, fewer readmissions, greater beneficiary engagement. Let's get them more involved in their own care to the extent they're able to do so. Some, with the right information, we can really motivate effectively. Others, we're largely going to be focused on. But again, if we know to focus on them early, it makes a difference. Physician engagement, because for them, if we can easily help them identify those folks, they want just as much as we do to be able to take care of those patients early rather than wait until they're very, very sick. And obviously something that could scale on a broader basis, because as I said a few minutes ago, there's a lot of need for this. So with that, I think that summarizes what I've got in terms of the background of TC2, the issues we face, the challenge we're putting forth to the group, and to some degree our definition of success. So does that come back to you, Isabel?
Yes, thank you, Dale. Thank you very much. For everybody on the call, we will take questions at the end of the presentation, and Laura is the second one and the last one to pitch a challenge today. So before we get started, I'm very excited to introduce Laura Gentry, the CEO of the Medical Center of Peach County, Navicent Health. Laura is a longtime friend of innovation. We have run several proof of concept at Laura's hospital, the Medical Center of Peach County, and quite varied too. I could recall a POC focused on no-touch disinfection system, another one on asset and staff tracking. We introduced virtual health solutions, devices, and other novel systems to Laura, who has always been receptive to the idea of looking at all problems from a new and a fresh lens. As a nurse and an executive, Laura brings her empathy to work every day for her teammates, her patients, customers, and in general for the community that her hospital serves. So it is my absolute pleasure to introduce you to Laura, and you can go on mute, and then I'll get off. Thank you.
Thank you, Isabel. This is Laura Gentry. I'm the CEO at the Medical Center of Peach County. We are located in Byron, Georgia. This is our hospital. It's 8 years old. We service the community of Peach County. Next slide. That's a little bit about the county. It tells me a little bit about the hospital, excuse me. We're a 25-bed critical access hospital. We have 14 emergency rooms. We treat about 22,000 emergency patients a year, which is really pretty busy for a small hospital. We have 1 operating room and 2 endo suites, and we have a rural health clinic located in Fort Valley, Georgia. Next slide. This tells you a little bit about Fort Valley. So the hospital is actually located in Byron, which is the east side of the county. But when you start going west, it starts getting very rural. The city of Fort Valley is the county seat. We have about 9,000 residents in Fort Valley. And then you can see us compared to almost 27,000 residents in the county. And then household income in Fort Valley is at 40,000 as compared to the state at 58,000. So that's a little bit of the overview of the county. Of Fort Valley. So the next slide tells you a little bit about how this all came about. So I actually met a pediatrician that works at Emory, and he's involved with this Pediatric Environmental Health Specialty Unit at Emory. I met him a couple of years ago, and he was telling me about a project he had been involved with that started, Fort Valley has a small college, Fort Valley State University, and there was a student there that was doing a project on environment and pediatric asthma, and was just having a lot of obstacles trying to understand pediatric asthma and getting involved with the families. And the project grew to include all these organizations, the EPA, the Pediatric Environmental Health Specialty Unit, an organization called Break the Cycle, and then Emory University. And he was telling me that they, were really having a hard time getting into the homes and understanding the dynamics of pediatric asthma in Fort Valley. it grew to also start including the mayor, and, you know, it just really grew, but they had trouble, you know, kind of moving forward with the project that they were working on. Well, it caused me to kind of step back and think about my hospital. We are adults, we don't admit children. But when I went back and looked at our emergency department, I realized we see a lot of children in our emergency department with asthma from Peach County. The next slide will show you a little bit about our volumes when it comes to the emergency department. We see around 75 cases a year of pediatric asthma. This shows you the ages. You can see the primary age is a little bit younger, 4, 5, 6, and 7. So school-age children were coming to the emergency room for their asthma. So it kind of brings you to pause, you know, to understand, you know, try to understand what's going on. Why are they seeking the emergency room for management of their asthma? The next slide. What we learned is overall there is a knowledge deficit about asthma, about things that trigger asthma, and also how to care for your children that have asthma. We've learned that it takes a lot of trust to gain the community's to build trust with the community, to help you get involved with them for education and helping them understand. Then we realized there was a knowledge deficit, not just asthma triggers in the home, but how to manage the triggers and recognize triggers outside the home. So like if you're doing little league sports, or if you're at school, what things are triggering your asthma. And then of course, more recently, you know, we have a lot of concern that the caregivers may not be seeking treatment for their children with asthma early because they're afraid of COVID-19. So they may delay health care altogether. So the next slide, please. This slide just kind of shows you the whole cycle of health disparities when it comes to health. You can see it, you know, ranges from, you know, in Fort Valley, it's not a new growing community. The homes are older. There's, you know, toxins in the environment. Of course, we talked about the asthma. There's lower income, lower educational level. A lot of the children live with grandparents who are older themselves and have their own health issues. Just limited choices. When you think about a city like Fort Valley, we don't have a large grocery store. There's no chain grocery stores there. There is like a food depot or something like that. But as far as the larger grocery stores, that's not available as either. So this whole cycle really kind of plays into the children with asthma. Next slide. So we started thinking, what could we do, you know, after we all got together, and of course we approached the Innovation Center and said, you know, there's got to be something more to help the children and their families understand asthma better, and, you know, the triggers and what they can do to try to prevent an asthma attack. We knew immediately that digital was the way to go. It's obviously a social influencer of health and everything else. We wanted it to be a solution that helped the children and their parents both identify triggers, and then what actions to take. If they started coughing frequently, what should I do? Is that a trigger? If yes, what do I do? We wanted the solution to be something fun. If you remember that slide that talked about ages, it's a younger group that we're trying to get to in addition to their parents or their grandparents or legal guardians. So it needed to be engaging for children, teens, parents, you know, all alike, and at the same time addressing the concerns that as clinicians we have. Another thing to consider with our solution is minimal broadband requirements. So when COVID, we have a rural health clinic, as I mentioned, in Fort Valley, and when COVID came onto the scene, we started really having to use telemedicine. And it became very clear that there were a limited group of patients that live in the Fort Valley, Peach County areas. It's more rural, that there was a drag on the screens. So we couldn't do a lot of face-to-face. It may be just phone. So that's just something that needs to be considered as we think about a solution. And then, as I mentioned earlier, we just want the educational elements to be embedded for children and the parents. What we wanted to get away from is the traditional education of a piece of paper. You know, what could be a fun solution to educate? Next slide. Of course, our impact, we want the children to be educated about their condition as well as their parents or legal guardians. Health literacy. So when you talk about health literacy, that has a huge impact on asthma, all healthcare, all obviously, but especially asthma in the community. We wanted to improve the overall health of the children in Fort Valley. I'd love to see a decrease visits to our emergency department for asthmatic, attacks in these children. And then, of course, we wanted something that's sustainable. Next slide. So mine's kind of an easy pitch. What I would love to see is just our children with asthma live happy, healthy lives to their fullest. We talk about stories. I worked with a girl that her nephew started his little breathing treatment, and they went in the kitchen and started cooking, and when they came back, they found him dead. They had waited too late to seek care because they didn't understand the triggers of the asthma and what to do once certain things start happening. So it's very real, it's personal. It's a challenge I didn't even know that we had until I was able to connect with the pediatrician that I mentioned. But once I connected and really started realizing what's going on with these children, and especially with school starting back, it just really became real personal for me that I'd love to see us come up with a better way to educate our children. That's my pitch, short and sweet. Thank you, Chris.
Thank you very much. And thank you both for some wonderful pitches. I know we're going to get the questions after AT talks about next steps here, but just to answer a couple, yes, copies of this presentation and recordings of this presentation will be available on the website. Presentation tomorrow. I don't know how fast we can get the recording done, but we'll get up very soon too. So AT Gimbel will now take us through what comes after tonight.
Great, thanks Chris, and thank you Laura and Dale for sharing more details on the two challenges. So I know we've talked about a lot of things tonight, so just to close us out, wanted to reiterate how the program works and is designed, and then close with some specific actionable next steps for those on the meeting tonight to go forward. So again, to reiterate, this is a 13-week program. It's not just tonight. And it's designed in a couple phases, where phase one is the early stage we're in now, about learning about the challenges and submitting a proposal. Phase two moves into prep for those who have been selected as a finalist. And then ultimately, this moves into action, becoming a beta partner and a test partner with Laura and Dale. So let me move into details of each of those sections here a little bit. So on the first one, on the proposal submissions, we've got the event tonight, which is what we're calling the reverse pitch, to let everybody know about the problems, get folks aware. This is actually a great opportunity for, I'm sure many of you on this meeting may say, I know somebody else who would be interested in proposing on one of these challenges or would like to get connected to what's going on here. The good news is there's still more time, so we encourage you to share this with others in your network. Next week on Tuesday, we're going to have 2 hour-long sessions with our champions, Dale and Laura, where you can ask much more detailed and technical and specific questions to them in a group environment like this, but much smaller, much more focused on their specific challenge. So there's one of those for each there. The next 3 weeks on Wednesday, so the 12th, 19th, and 26th of August, we're going to have a coach's office hours where myself, Chris, Christopher, Isabel, and some folks will be on the call to help you, whether it's, hey, it's a process question of how this works, it's feedback on what you're working on, it's suggestions on how to craft the proposal. We'll be available for an hour each of those next couple weeks to support you and anybody who's interested in proposing on this challenge. And then all this builds up to Friday, August 28th at 5 p.m. is the submission deadline. I'll go into more details here in the next slide of how to tactically do all these things. But good news is you will have a couple weeks from today until then to do your own research, participate in the sessions with Dale and Laura to go deeper, work with the coaches or any of your advisors, and then have time to prepare a solution. And then we'll take about a week to review those and whittle those down to a couple of finalists for each of the challenges, which will then move us into phase two. So then phase 2, as you see, is the next 8 weeks, where similarly we'll have, just for the finalists, Q&A sessions again with Dale and Laura, a couple of those to go deeper, as now we're getting closer to refining the approach, refining the solution. Office hours for the coaches will be every week as well again. And we'll also bring in others from the community who may be experts on certain topics based on the challenges and what we're working on to help support you. We'll have a dry run, and then we'll conclude on October 29th with a forward pitch, where again, this was the reverse pitch where you heard from Laura and Dale presenting to the community. On the 29th will be the forward pitch, where the finalists will present back to Laura and Dale, as well as any folks on this call or otherwise in the ecosystem who want to hear that. That meeting on the 29th will be open to folks as well, similar to how this one was. And then lastly, post that, again, this isn't just the 13 weeks. This will go beyond the 13 weeks for the winners to move forward with Laura and Dale to help solve their problems. So that's a lot, but I wanted to reiterate this is more than just tonight's event. This is an ongoing program that has multiple points to interact, whether you're interested in proposing or just want to be a part of the process along the way. Next slide, Chris. So now, very tactically, what do I do? Where do I go? So we're in this phase 1 right now, we talked about, for proposal submissions. The first thing that we would encourage you to do, if you are interested in proposing one of these challenges or know somebody who is, on our website, and JC will show you these things in a minute when we wrap up the Q&A where to find them, but we've created a declaration of interest form. It's a simple form, but what it does is it lets us get your contact information specifically and let us know what challenges you're aware of, so we can send you specific information around the champion sessions and the office hours and any other material that may come out specific to those challenges. So that helps us to help you be better prepared to submit a proposal. As I mentioned, on the champion Q&A sessions, August 4th, challenge 1 with Dale will be at 2 o'clock for an hour in the afternoon. Laura will be at 10 a.m. And the links to register for those will be on the website as well under the schedule section. Again, JC will show you those when we wrap up here. And then same thing with the coaches' office hours. There'll be 3 to 4 p.m. on several consecutive Wednesdays. Those will be available for you to click and register on our site as well. And then lastly, and most importantly for this phase, is the submission deadline of August 28th. On the website, we have listed sort of the process for submitting. All you will do is upload a PDF to the website. And on the website, we describe some of the things that we would like to see in the presentation in terms of your company overview, some of your contact info, which solution, your experience with the solution, and moving forward, you know, how you're going to measure success, some things like that. So that's outlined on the website. So we ask for those elements to be in there, but it's not mandated that you need exactly 10 slides with exactly these things and forms to fill out. We want to be a little open-ended for you, but give you some guidance of what to put in. So that's phase 1, the proposal. And then again, a week after, we'll announce the finalists, and then those finalists will move forward into phase 2, which will be just the finalists plus the coaches and the champions. And then mark your calendars again for October 29th, that we will have that forward pitch back. And anybody on this meeting is invited to attend that, as well as others. Will be open to the public, similar registration. And we'll see where COVID goes. It may be virtual. It may be at Navicent's facilities down in Macon. We'll be flexible as we move to that. So hopefully that helped you better understand the full 13-week process, some specific next steps, and where to find those. And again, you know, thank you all for attending this, and help us spread the word to others who you think may be interested in proposing on these challenges. So with that, Chris and JC, I'll turn it back over to you to take some questions and wrap up.
Excellent. Thank you very much, AT. JC, I know you've been filling some questions, and let's go ahead and just open it up if you have some questions for Dale, Laura, or AT.
Yeah, we do. Thanks again. And I saw that Dale has been answering some. So if you guys can see that, go back and review those. But why don't we start at the top with Dale? We're just going to try and make our way through. So Dale, if you're ready and unmuted to take these questions, we'll start with one here. Are there key clinical metrics that are used to identify rising risk patients?
Well, the answer is yes, but I think the right way to look at this is more comprehensively, because the richest data set that we have, as I indicated during the presentation, is the claims data. So claims is obviously a measure of your activity. In other words, you know, the number of interventions, the type of interventions, and what have you that you have had with any part of the overall medical system. And that is far and away the richest data set. So one of the elements that will be important is how do we make much better use of the huge amount of information that is coming to us monthly from CMS. On the clinical side, those early indicators are going to be condition specific. You know, in other words, if we've got somebody who we're worried about, you know, trending towards kidney failure, it's the GFR. You know, we're going to want to see the lab values for that. In many cases, those are lab values or test results. And that's the area that typically, if we're trying to get that information, we are having to reach out and pull rather than have it pushed. But think of it this way, we're not looking for that pull issue necessarily to be solved, because we know that that is a big one. The bigger issue is, with the comprehensive claims data we have, how much flexibility can we have with that for some of our predictive modeling, and how easy is it to add other data sets as we come in? How do we do this? Because right now, when that information comes in, it's a one-off. We look at a patient and say, okay, there's, you know, claims activity shows an increase here. Are we seeing some lab values? Can we go in, look to the EMR and pull? If this information is easily and more readily available and analyzed, I think it's easier for us to move forward. And that becomes particularly important because when we move towards making better use of the HIEs, we are going to have those other data sets. And that, I think, is probably the way to look at this, is a combination of activity measures that are claims-based and diagnosis-driven, because the diagnosis information is in all the claims, and then being able to selectively, you know, creatively use that to then selectively add details as we can get a richer picture for some or all patients, either by practice, by diagnosis, or by geography.
Awesome. Yeah, thank you so much. Well, let's go on to one more here from Chris earlier. He had said, how much does previous year's HCC and RAF score impact future year payments, and how much, and that's question number one, and then how much does individual coding practices impact this?
Okay, we've got someone who knows a little bit about the system within which we work. The HCCs are key, because that's Medicare's way of knowing effectively how sick, what is the burden of illness for given patients. So actually, if there's an area that we have focused on very effectively as an organization, think of it this way. There are two ways by which you position yourself effectively to do well in a two-sided risk model. One is to put in the effort to make sure the benchmark, the target, effectively represents the burden of illness. Okay, and the second is then being able to effectively manage against that. I think we do quite well in the first. Just to give you an idea, when I said our population is 46% sicker, that tells you that our average HCC score, where the average Medicare population across the country is a 1, ours is a 1.46. Well, 2 years ago it was a 1.2. So we've effectively recognized the first thing you've got to do is make sure you document burden of illness. So we see that as less of an issue. Now that we know how sick a lot of these folks are, it's more how do we get proactive with that, because the practice had been trained pretty effectively to code and document better.
Great. All right. Well, I'm going to, Dale, there is a lot of questions, and so we'll follow up, but I'm going to switch over to Laura real quick, just so we can make sure and get a couple of those. And again, there'll be time during the cocktail hour to address some more. So, but this one's going to be for Laura.
Sure.
I do want to touch on how has COVID affected the census? Does success mean fewer kids in ED or satisfaction or improved asthma knowledge?
Well, it's kind of two different questions in a way. For the first question, how has COVID affected the census? I guess, you know, the concern is we're concerned that people aren't coming to the hospital and managing healthcare issues during COVID. So that's one concern that we have. Although census overall is up, emergency department visits are down. So we are a little concerned that people aren't seeking healthcare like they should, and maybe putting things off. So when they are coming, the patients that we do see are a little sicker. Now, does success mean fewer kids in the ED, or satisfaction, or improved asthma knowledge? You know, we would like to think that if the children aren't coming to the emergency department and they're being managed in their primary care doctor's office better and able to manage themselves at home and not get to the place where they have an asthma attack to the point they have to come to the emergency department. We hope that, you know, education, you know, knowledge is key. So we hope that improved knowledge could translate to fewer asthma attacks that are so severe they have to come to the emergency department.
Great. And I do think this is another one for Laura. So correct me if I'm wrong, but this is from Anand. And he said, have you considered partnering with local home health agencies in the past to provide caregivers to do social work from Navicent and to provide phone follow-ups?
So we do.
Yeah, sorry, go ahead.
Yeah, I'm not sure if that's for me or Dale. Both of us could answer that question because, you know, it could apply to either one of us. But yes, we do. We have a children's hospital. We actually have a camp for children with asthma. We do a lot of things working with the children with asthma. But what part of our challenge has become, as I mentioned, a lot of our children live out in rural areas. And so, you know, we're trying to get the message to them, the education to them, and, you know, they may not be able to participate in a camp because they can't get there, or that kind of thing. And then as far as home health, you know, you have to qualify for home health. You can't just, you know, say I want home health and them come out there. So, and a lot of the children are actually on Medicaid. So Medicaid, again, would limit some of the resources that they may have. So. Okay.
Great. And now I'm going to pop back to Dale and try and get one more question, and then maybe some generic questions, and then we'll dive in. I'll show you some next steps, and we'll be here still throughout the cocktail hour. But Dale, for you, there was a specific question. Does this solution have to be specific to TCT, or can TCT leverage a solution that's being built to support consumers? So I wanted you to answer that for everyone.
Yeah, okay, because I did respond to that question. I think the thing we need to keep in mind here is when you look at this, the primary value of the data and the analytics and the insight is to help inform physicians, okay, as to how they can better manage their patients. How do you give physicians the longitudinal view of a patient that goes beyond the specific visit experience they have with them, and that's, you know, broader data. And secondarily, how do you then provide extended support? You know, what I referred to earlier on is kind of the population health center interventions and the like. So when it comes, you know, right down to it, I think that the consumer focus is one that I first responded to that question by saying, you know, it's got to be HIPAA compliant. And then the more I thought about it, I'm like, okay, well, that's, you know, self-evident in most cases for folks who have any familiarity with healthcare. But I think part of it is the focus. Can that be redeployed in a way that is usable, more from the practitioner, care coordinator, care manager perspective? And I think if the answer to that is yes, then sure.
Awesome. One other thing is, Anand did clarify, so I'm going to ask you the same question that I had asked Laura, in that have you considered partnering with local home health agencies in the past to provide caregivers, or do social workers from Navicent provide phone follow-ups?
The answer is yes to both. And what I mean by that is when I talk about the population health centers, we do not employ all the folks in that. That is actually because we do this regionally, and Navicent, the Macon Bibb area, is only one of the 5 regions. We actually ask them to bring their resources to the table including social workers, if they have them available for that purpose, home health care, if they have that available for that purpose. And then what we do is we augment the resources that they have, so that we're not trying to reinvent the wheel, or we're not trying to bring folks in from outside a market that may not understand some unique market dynamics, or may not understand some of the strong players and resources that are already available. So yes, we do that.
Okay, great. Now I'm gonna have, for both of you, I've got a question, if you can both speak to this. So I'll have Dale first and then Laura. Would you both consider a telemedicine solution?
We have a telemedicine solution that we have been using with the advent of COVID back in March. Of our 85 practices, on March 1st, 2 were able to do telehealth. Today, the number is 78. So we had to, that was what we focused on, to the extreme, March and April, a simple solution that worked from a telehealth standpoint. So what I wrestle with is, if we already have that, I'm not sure that's something we need. I see the need from our stand more of the productive analytics that really help us focus our resources.
Okay, great. And Laura, if you want to pop in on that.
So I think our thought was something more, like Dale said, telemedicine's already out there and people are using it. But on our problem, we were hoping for something more that was just in time for the child. Something that, oh, I'm coughing. What do I do now? Because coughing can be a trigger, for asthma, and something they could just connect, not necessarily with a person, but maybe an algorithm or a questionnaire that they could get on their little phone and answer, or find out what they got to do, or something like that. Not necessarily telemedicine, but something they could do in their room at night when they feel like something's changing and they need to answer a question.
Awesome. Okay, well, thanks, y'all. I do want to go to a couple generic questions people have just been asking. So one of those is about, when pitching solutions, how does IP and confidentiality work? If we propose a solution, will all attendees see it? Are NDAs signed, etc.? And so perhaps Chris or AT or Christopher could speak to that, or one of the CEOs might as well.
Yeah, let me take a cut at that. So your information will not be shared with anybody else besides the selection committee. So it'll be Dale or Laura, Isabel, and then those three of us who are part of that selection committee. Just nobody else sees it. There will be an NDA signed. We're not asking either side to share super private information during phase 1. If you're selected to go to phase 2, you'll be asked to sign an NDA. It'll be a mutual NDA to protect yourselves and Navicent Healthcare. Because at that point, then they may be sharing a lot more detailed information for you to actually run with your application to make sure it works and you're ready to present something at the board pitch. Isabel, anything to add to that?
That was perfect, Chris.
Okay, great.
Right. And I'll do one more question here before we dive into a couple more logistics, but I've had a couple questions just around funding. Do the finalists receive funding? Will these officially get funded? So again, Isabel kind of spoke to that a little bit in some of the chat. I don't know if everyone saw, but do you want to kind of speak to what you'd said there, Isabel?
Around the funding?
Mm-hmm.
So right now for the 13-week program, there is no funding available. And then when we talk about the finalists, the winner, not the finalist, the winner, for each of the challenge, and then we talk about going into beta testing or proof of concept, then it's another game. Right now there is no funding. Right now we would go to the grant market, but things might change by then.
Awesome. Okay.
The other thing, JC, I'll just add on that. There are folks in the ecosystem that are on this call that are investors and are supporters of the community. And part of our hope too is connecting some of those folks that may be able to help you with an angel or friends and family, or even a more substantive thing if necessary.
Yeah, great.
Thanks, Iti.
Well, Chris, if you want to stop sharing, I'll go ahead. I wanted to just show you guys, as AT had mentioned, I want to share my screen so that you all can see what I'm looking at here. But things that I wanted to go through is he mentioned that declaration of intent. Can you guys see what I'm sharing or no?
Yes.
Okay, great. So that first is we're going to send this link along so that everyone can see it. This is kind of what we're talking about here. It is on the website, GA Healthcare Innovation Challenge Declaration of Intent form. And this is, as AT was mentioning, this will kind of give us a good idea about what you're interested, who your questions are for, and this will also allow us to send that information along to you. This is also located on the resources page. So if you guys are having questions, I do want to direct you here. We've got key contacts, of course, but if you're looking to submit to that declaration of interest, that is here where you can submit, and it also registers you. It allows us for us to send you communication about that 8-4 session. One other thing to note about this is if you do want to ask a question, we're gonna try and address these. We've got a happy hour still, so we've still got time to chat. But if there's other specific questions that we can be giving you or setting us up so that we can prepare for that session, feel free to submit here. And one other thing that I want to show you is AT has mentioned that the links will be on the schedule session, and they are here. So if you want to just pop onto that Zoom session for either Dale or Laura, it's going to be located right here, and you can click there and join right away. So we've tried to equip you guys. If you do have questions, you can always email us, but everything should kind of be up here. Tonight, this link will switch over to actually link directly to that declaration of intent of interest form, just to give us insight. So I hope that kind of covered everything, Chris, as far as we were talking about.
Well, and JC, so people have been asking, can they get a copy of the presentation tonight, or can they get a copy of this recording? Because you mentioned we're recording it at the front end. Where will those be on the site?
Yeah, so we're going to send out, I'll have the video ready for you. It should probably go out within 24 hours. So it should go into the email that you registered for the event with. And then we will also link it online under the resources page as soon as I can get it uploaded for you. But as long as you've registered with your email, you should be able to find those things pretty easily. And the links to the decks will be located under the challenges section as well. Directly, I can share my screen one more time for you, and you'll see it. We've got the challenges page here, so you'll see more information to come. We'll have more information under each of these sections as well.